Dear colleagues, ladies and gentlemen, it is my pleasure today to talk about rivaroxaban and to share with you some of the experience we've had in Germany. And I'm coming from Freiburg, which is close to Munich, but also very, very beautiful, and everyone invited to come and see the Black Forest. Yeah, here are my disclosures. Now, the way I would like to do this is I would like to start out talking a little bit about the pharmacology of rivaroxaban. We've already seen a summary slide of the four NOACs, and then go over the platform of evidence we have for rivaroxaban in the different indications. In stroke prevention in atrial fibrillation, the ROCKET trial, cover a couple of subgroups here, then move on to DVT-PE treatment, the Einstein program, and have just a brief few words about the potential new use of rivaroxaban in the setting of ACS. Before I go over a couple of practical situations and cases, and there I would really sort of ask for your participation, and then end with what I call individualized therapeutic approach. Now, if we look at the pharmacology, and here are the three NOACs that are currently on the market, then of course there's rivaroxaban has a very different mode of action of that of dabigatran. It's a factor Xa inhibitor and not a thrombin inhibitor. If we look at the other markers of the pharmacology, then we basically see it's not a prodrug. It's a direct-acting drug with a high bioavailability, about the same sort of. They all have pretty fast-acting, comparable to what you see when you actually inject IV heparin. And the half time is about 7 to 11 hours. But I think the most striking and probably clinically relevant difference is something we've already talked about. That's renal elimination. And with both apixaban, rivaroxaban, this is about 30%. It's 80% for dabigatran, and I think that's clinically meaningful. And one of the features that determines, in my clinical practice, which patient I give which drug. Now, all of the NOACs have been tested in vast clinical trial programs. They've been started out in the VTE prevention. All three are licensed now for stroke prevention in atrial fibrillation. Rivaroxaban has the added advantage that it also holds a license for treatment of DVT-PE, and just recently also for a subgroup of ACS patients receiving aspirin clopidogrel for secondary prevention in ACS. But we'll come to that in a little more detail. Now, I'm sure you're all familiar with the ROCKET trial. This was the trial that tested rivaroxaban in ASPAF, about 15,000 patients included. It was a rather diseased collective, patients with atrial fibrillation, at least two risk factors. The mean CHA2DS2-VASc score in that study was about 3.5 compared to 2.1 in the RELIVE trial. If we look at primary endpoint, stroke, systemic embolism, just the same. If we look at the efficacy data, then in the ITT analysis, there was non-inferiority. However, when we actually looked at the patients on treatment in the per protocol analysis, there was also superiority for rivaroxaban with numerically lower event rates. And if you look at safety, the primary endpoint was unchanged, but, and this has been pointed out already by Professor Kam, critical bleeding, fatal bleeding, and particularly intracranial hemorrhage was also markedly reduced by rivaroxaban. And I think that's one of the strongest data we have. Meanwhile, we have four drugs. ENGAGE-AF has just been presented at the AHA meeting. All four trials show at least the same efficacy as warfarin. In my opinion, they are all superior. And on safety, they all show reduced intracranial bleeding. So I think that's a very strong argument for these new substances. If we look at a couple of subgroups, here I brought you the data of those renally impaired. Of course, those renally impaired here, creatinine clearance 30 to 49. Overall, the event rate is higher, but if you look at the effect of rivaroxaban, those curves mimic each other in the overall collective. So numerically, there are lower event rates, and if you actually look at the individual points, then you see, yes, you also see numerically lower hemorrhagic strokes, though this is no longer significant here. And if you look at the bleeding safety endpoints, then you do have a significantly reduced critical organ bleeding, significantly reduced fatal bleeding also in those with renal impairment, supporting that this is actually pretty safe to use this drug in this patient collective. What about in patients that already had a stroke compared to those that are stroke naive? Again, of course, stroke is a major risk factor for thromboembolic events. It's a strong part of the CHA2DS2-VASc score that we're calculating in all patients. So we have higher event rates, but again, numerically, rivaroxaban, the red curve or purple curve here, does better as seen in the overall collective. And again, you see here, hemorrhagic stroke is a little more mildly reduced as the overall collective, but by tendency it's the same. And if you look at the bleeding endpoints, you also have reduced fatal bleeding and reduced intracranial bleeding. Now, we've already talked a lot about CTTR, time in target ratio. Of course, that's always been a huge criticism on warfarin. In the Relight trial, in the Rocket trial, it was about 58%. In Relight, it was a little higher, Aristotle too. Still, 60% is not good, and I think it's just sort of what we have to live with in the real world, and we are not getting much better. If we look at the CTTR ranges, again, put into different ranges here in the overall collective of Rocket, and you've seen this picture already in Professor Kamp's talk, there was no major influence of CTTR level on the effectiveness of rivaroxaban. And then finally, myocardial infarction. You've seen the data of dabigatran, where at least there is some suspicion that it might increase myocardial infarction rates, albeit by a small increase. There is a similar meta-analysis for rivaroxaban that actually shows that you have lower infarct rate, and also we have very favorable data in the setting of ACS at the lower dose, where we will come to. So what about DVT and PE? This was tested in the Einstein DVT and PE program, two separate studies. It was now the specific feature with rivaroxaban here is it was given from the first day on for the first 3 weeks in a loading dose of twice daily 15 milligram, and then the regular dose of 1 times 20, compared with the standard comparator enoxaparin for at least 5 days, followed by overlapping VKE therapy with warfarin. What did we observe here? Well, if you see the curves here, 3,500 patients included in Einstein DVT, then you see numerically rivaroxaban did better. It's achieved non-inferiority. It almost achieved superiority in this trial. And if we looked at the clinically relevant first major or clinically relevant non-major bleeding occurring during treatment, which was the first safety endpoint, we observed no difference in this collective. What about Einstein PE? In pulmonary embolism, again, about 5,000 patients here, same regimen. There was basically for the primary endpoint non-inferiority shown. If we looked at bleeding, a marked reduction of major bleeding by about 51%. That was actually significant in this trial. Now, what was interesting with Einstein PE is that about 20% of the patients included in Einstein PE fulfilled the criteria fragile patient. That was age greater 75 and a body weight below 50 or a creatinine clearance below 50. And of course, these people by nature have higher event rates. Yeah? Event rate in the rest of the population 1.6, here 3.1. Also, bleeding rates were increased in this population. Now, what was interesting to observe is that the so-called fragile patients here profited particularly from the treatment with rivaroxaban. Particularly major bleeding was reduced here by 74% in this collective. Now, of course, the big question is, what do we do after after a successful treatment of VTE? And we all know there is a certain rate of recurrency, and it largely depends on whether we have idiopathic or secondary VTE. In idiopathic VTE, recurrency rates are up to 40% within the next 60 months. So, based on this, the Einstein extension trial was designed to look what happens. Can we further reduce the risk at a justifiable bleeding risk, the risk of recurrent thromboembolism after successful treatment for 6 or 12 months with anticoagulation? So about 1,200 patients were randomized again to rivaroxaban or placebo. And as you can see here, obviously there was a tremendous superiority for rivaroxaban compared to placebo. Of course, bleeding rates were higher. The first major or clinically relevant non-major bleeding, which was the endpoint, from 1.2 to 6%. However, when we actually just look at major bleeding, there was only a minor increase from 0 to 0.7%, which looks much better than the trials that originally investigated the same scenario with warfarin. So finally, third new indication for rivaroxaban, that's the acute coronary syndrome. Now, of course, we know acute coronary syndromes is the mainstay of antiplatelet therapy. And we've seen tremendous successful strategy in more effectively inhibiting platelets by introducing aspirin clopidogrel, and then the third generation P2Y12 inhibitors. At the same time, however, we've also incurred an increase in bleeding risk, and somehow I think we are now in a setting that a further reduction or further inhibition of platelet inhibition will probably be not anymore a fruitful strategy. Now, at the same time, we have data that the coagulation cascade is actually activated and persists to be activated for a very long time in patients after myocardial infarction. Even after 6 months, you still have F1, 2 thrombine products in blood. Now, based on this, very early on already, with, the concept was tested. What happens if you actually inhibit both sides, if you come with a platelet inhibitor and if you on top come in with warfarin? And yes, lower events were observed, but at the cost of much, much more bleeding. But obviously, with the new drugs, this gave a new spark into this direction to actually investigate this. And rivaroxaban was given here in a very low doses, 2 times 2.5 or 2 times 5 milligram per day in patients with ACS on top of aspirin or aspirin clopidogrel. For 95% of the patients, it was aspirin clopidogrel included in the trial. And the data were very, very favorable. We see death from cardiovascular causes, myocardial infarction or stroke as the primary endpoint reduced by about 16% here. What is even more impressive, death from cardiovascular causes reduced by about 34%, and even the hardest endpoint, all-cause mortality, death from any cause, also reduced in this trial. Of course, at the cost of an increase in TIMI major bleeding here, as you can see. However, this is about in the same ballpark as we've seen it with the introduction of the third generation P2Y12 inhibitors, and fatal bleeding was not increased. Of course, there are many questions that remain here, particularly what about the combination of rivaroxaban with the novel antiplatelets, ticagrelor and prasugrel. Some of that may be answered through studies such as the Pioneer trial, but I think particularly for patients with a low bleeding risk and a high thrombus load, this may be a good strategy. So finally, I'd like to run over a couple of cases with you. And the first case I brought to you is a 78-year-old woman with new onset atrial fibrillation. She suffers from coronary 2 vessel disease, had an acute MI 2 years ago, also has arterial hypertension. Standard case we see every day in cardiology clinics. Creatinine clearance is about 40. Otherwise, she's in good health condition, and she's been referred from another center on enoxaparin twice daily since 2 days. Now, my first question, of course, to you as the audience is, does this patient need long-term anticoagulation? Please raise hands. Of course she does. If we calculate the CHA2DS2-VASc score as we should, then we come up with about 5 points. Now, honestly, who of you on a regular basis calculates a bleeding score? At least I see some hands in the audience. Usually there are no hands in the audience. I think it's important to calculate a bleeding score. Now, many people say, why calculating a bleeding score? If you have a high CHA2DS2-VASc score, you probably also have a high score of bleeding. Yes, to some extent this is true because the parameters are similar. However, I think it's important to become aware of the risk. And it's particularly important to become aware of the risk in days where we no longer have to control our patients on a regular basis with a NOAC. But just that we do not have to measure the anticoagulatory effect, for me personally, does not mean I should not see my patients anymore. And I think bleeding, renal function, age are the 3 main factors that determine sort of the frequency, how often I see a patient on a NOAC. So it's not so much about deciding whether to anticoagulate, but more appreciating the risk. So, next question. What would be the agent of choice? And I know this is arguable. And we can argue it. What would be the agent of choice for this lady? Who says warfarin? Dabigatran? Rivaroxaban, anyone raising the hand? Or aspirin? Now, we've already made the point, if we look at the guidelines, aspirin or antiplatelet therapy, as we've heard from Professor Kam, is more or less out of the guidelines since the update in 2012, because we are almost incurring the same risk of bleeding, but we are having far less efficacy. And there is a strong push for NOAC therapy. So what do the guidelines exactly tell us? They tell us to use NOACs whenever we have, in a 1B recommendation, whenever we have problems in our inability to attend or monitor INR. But they also tell us with a pretty strong 2A recommendation that they should be generally preferred over dose-adjusted vitamin K antagonist therapy for most patients based on the net clinical benefit. And I think that's pretty strong data. So I think first answer is yes, and we should go for a NOAC. Second answer, I think there are a couple of issues or a couple of traits in this patient that would persuade me more to use a factor 10A inhibitor instead of a thrombin inhibitor. That's particularly the renal function, the age, and then we can debate coronary heart disease. Personally, I do not see a contraindication for dabigatran in patients with heart disease, but I'm a little careful in those that already had a myocardial infarction and are in the sort of top category of risk. Yeah, here you can see this just once again, that with the factor 10A inhibitors, apixaban, rivaroxaban, renal function gives you just much lower accumulation than with dabigatran. So what dose would we use in this patient? And by the way, these are all doses used by rivaroxaban in different settings. 1 time 15 milligram. Because she has impaired renal function, standard dose would be 1 time 15 milligram. So 1 time 20 for all others, and from creatinine clearance 15 to 49. At least this is the license we hold in Germany. I realize in some other countries it's actually limited to 30. 1 time 15 milligram. How would you switch? Also very practical, but I think relevant for the everyday situation. If you give enoxaparin twice daily, you would actually give the new drug at the next dose interval. If you're using, for example, fondaparinux in a once daily regimen, it would be after 24 hours, also at the next regular dose interval. If you're switching from heparin, you just stop heparin, throw in the drug, and this is actually true for all NOACs, because they are so, as the heparin fades off, the others will be in action. If you switch from a vitamin K antagonist, my general recommendation would be at least INR below 2.5, better 2.0. This is out of the SPFC, which I think is a little too much. And if ever you have to switch back to a vitamin K antagonist, you particularly with rivaroxaban, you would actually assay INR at trough levels just before you throw in the next dose, and once it's over 2.0, you would do that. So a major concern, of course, for many people is bleeding. We've already heard about issues with gastric bleedings. Rivaroxaban also has some issues with gastric bleedings. Apixaban is a little better in that context. We'll probably hear about that. I brought you a case here that a patient we treated with rivaroxaban, 60-year-old man, 1 time 20 milligram for AF since 2 months. He presented in the ER with acute symptomatic gastric bleeding and had a drop in hemoglobin by 5 points. So what do we do in a situation like this? Many people are concerned about antidotes. So far, we do not have an adequate antidote. I think we do not have an adequate antidote for warfarin either. Vitamin K is very slow. Of course, you can give FFP. FFP in the setting of NOACs will not help you much. So basically, my recommendation here is do what you always do in bleeding scenarios, fluids, local hemostasis. And if you're really running into trouble, and we've been in trouble in 2 patients under NOAC therapy, we used PCC. And that's basically also what is shown in the ESC guidelines. Very severe bleeding, use PCC. And then one more case, a surgery case, also something very relevant in clinical practice. 77-year-old female, we treated her with rivaroxaban for AF, and she came in and had to undergo urgent cholecystectomy. Again, I think it's important to know when did she actually throw in the last pill, just to know whether we are in the building up or the fading off phase. Secondly, I think it's absolutely vital to talk to surgeons. How urgent is it? If it is really an emergency, then we have to go for the surgery. Be prepared with blood products. I would not preemptively ever give PCC, though, in this situation, but probably have it ready. In elective surgery, for rivaroxaban, at least 24 hours. Again, in renally impaired patients, I'm more cautious and probably would advocate 48 hours. Yeah, and that brings me to the end of my talk today. I think there are a couple of things about NOACs. First of all, I think we have very strong data for NOACs. The strongest data for me is that we have 4 different studies, 4 different companies in AF. And every time we see this marked reduction in intracranial bleeding, I think that's something our patients should profit from. Secondly, I think we have the beauty of having 3, soon 4 substances. Each of them have individual traits, so we should probably use those hints and traits, since we will not see a head-to-head trial anytime soon, to individualize treatment. And thirdly, I think rivaroxaban at the moment offers the advantage of being licensed in various indications, AF, DVT-PE, and also in the coronary situation. For us, that's pretty important as a cardiology center. If we think about future developments, triple therapy, and so on. Thank you very much.